So question is, a sigmoid configuration along with tapering beak-like deformity at the lower esophageal sphincter on barium swallow is a feature of. So they're showing you this, that there's a beak-like deformity, so it's like a beak, and there is a dilatation in the lower esophageal sphincter. So they're asking, it's a feature of diffuse esophageal spasm, squamous cell carcinoma of esophagus, Achlasia cardia, or the Barrett's esophagus. So answer is Achlasia cardia. So this is seen in Achlasia cardia. So what is Achlasia cardia or Achlasia of esophagus? So the pathophysiology is, in Achlasia, this hypertonic lower esophageal sphincter. So in the lower esophageal sphincter, the tone will increase. So tone will increase, which leads to failure to relax in response to the swallowing wave. So when the swallowing wave will come, so it will not be able to relax. Number two, there will be failure of propagated esophageal contraction. So even the contraction will not be able to be done, which leads to progressive dilatation of the gullet. Gullet means esophagus. So normally what happens, that peristalsis push the food down and the lower esophageal sphincter relaxes to allow the food go through into the stomach. But in the case of Achlasia, the food stagnate and esophagus dilate, and the lower esophageal sphincter fails to relax because its tone is very high, it's hypertonic. What is the cause? In real, we do not know the cause. So cause is unknown, but we have seen it to be associated with the autoimmune diseases. Which autoimmune disease it is associated with? With the type 1 diabetes mellitus, with the SLE, with the rheumatoid arthritis, and with the Sjogren's syndrome. Secondly, what has been also seen, that there is a defective release of nitric oxide by inhibitory neurons in the lower esophageal sphincter has also been reported. Number three, third pathophysiology has been seen, that there is a degeneration of ganglion cell in the sphincter and the body of the esophagus. Fourth, it has been seen that in the later stages in the brainstem there is a loss of the dorsal vagal nuclei. And number fifth, it has been seen that with the infection of Trypanosoma cruzi in the Chagas disease, it causes a syndrome which is clinically indistinguishable from Achlasia. So these are the pathophysiology, that is the etiology. Now the clinical features. So clinical features, first is dysphagia. It is typically to both solids and the liquids. Secondly, there is regurgitation to saliva and the food. Number three, there is a chest pain due to esophageal spasm. So patient can present to you with these characteristics, like there is dysphagia, he is not able to take solids and liquids both. There is regurgitation to saliva and food. There is chest pain due to esophageal spasm. Around 1/3 of the people have weight loss. As the disease progresses, dysphagia will worsen, esophagus will empty poorly, and there will be nocturnal pulmonary aspiration can also develop. Last is that Achlasia predisposed to squamous carcinoma of the esophagus. So we have seen that the Barrett's leads to adenocarcinoma of the stomach, adenocarcinoma, while Achlasia leads to squamous cell carcinoma of the esophagus. What are the investigations you will do to find out if it's Achlasia cardia? First is endoscopy. Endoscopy you have to always do. Why? Because you have to rule out the carcinoma, because the carcinoma can mimic the Achlasia, and that's why carcinoma is lead to in this condition will be known as pseudo Achlasia. Second, we can go for the barium swallow, on which the question was framed that there will be tapered narrowing of the lower esophagus. In the late disease, the esophagus body is dilated, peristaltic, and food filled. And the last is gold standard, the manometry. In the manometry, there will be high pressure, non-relaxing lower esophageal sphincter, where poor contractility of the esophageal body. Now, what is the management? So you have diagnosed it to be Achlasia cardia. Now what you are going to do? So first is endoscopic. You are going to do forceful pneumatic dilatation of using 30 to 35 millimeter of diameter balloon, and it is going to improve symptom in about 80%. Some people may need more than one dilatation. So number one is forceful pneumatic dilatation. Number two, you can also inject botulinum toxin into the lower esophageal sphincter, but we have seen that the relapse is common. And secondly, when you're going to repeat it, the response is going to worsen. So botulinum toxin is reserved only for the frail and elderly patient. Now number three is there is more technique. This is known as the POM, that is per-oral endoscopic myotomy. It's a newer technique, but it is done only in the specialist centers. Now, if after endoscopic treatment, we can go for surgical treatment. So surgical treatment is Haller's operation, in which we do the surgical myotomy. It can be done laparoscopically also and open also. Second is more invasive than dilatation, but it is more effective. But what is the problem? After you have done this dilatation and myotomy, now the other thing, the other spectrum will appear, that is there will be gastroesophageal reflux, because now the lower esophageal sphincter is not functioning, so there will be reflux into the esophagus, so there will be severe esophagitis due to poor clearance. So that's why whenever you are going for the Haller's myotomy, you should also do partial fundoplication so that the reflux do not occur. So it's an anti-reflux procedure. Third thing is, you also go for PPI therapy after the surgery so that the esophagitis do not occur. So this is about the Achlasia cardia.